Welcome to May 2022 edition of the ASC eJournal presentation. I'm Dr. Rezai, the chair of the eJournal committee, and I will be moderating this session and start with a very brief introduction of our panel. Dr. Nawgiri is a member of the eJournal committee and will be the presenter. She is currently the Director of Cytopathology Division and Cytopathology Fellowship Program Director at the University of Texas Medical Branch in Galveston, Texas. We are also very grateful to have with us two of the authors of the paper to be presented today. Dr. Sandy Liu is an assistant professor of University of Toronto and a consultant cytopathologist at the University Health Network in Toronto. Her research interest includes application and expanding the role of ancillary testing on cytologic specimens, hence the topic of our discussion today. And she is passionate about teaching trainees and pathologists about the wonders of cytopathology. Dr. Heather Ruff is currently an assistant professor of University of Toronto and the director of cytology at the University Health Network, Toronto General Hospital. In addition to cytology, she also has subspecialty fellowship and expertise in medical microbiology. With that very brief introduction, I would like to again thank our authors and our presenters for preparing the talk for today. And I will be on the background, and I apologize for me not being on the webcam because of the technical difficulties. But I will be monitoring the questions as come. Please use the question box in your panel, and I will be monitoring those questions. And the last 5 to 10 minutes of the discussion will be devoted to answering your questions. With that, we'll just go ahead and I'll let Dr. Nawgiri to start the presentation. Thank you.
Thank you, Dr. Rezai. So I'm going to carry on now and start off with the objectives. I'm very excited about the talk because of what cytology can do and how we can expand what we can do in cytopathology. So apart from that, to have both the authors, the lead authors at this presentation has been extremely, extremely valuable. Dr. Ruff has been pulled away to a procedure, but she will be joining us midway through the presentation. I'm going to start with the objectives, talk a little bit about the background, and then Dr. Liu is going to present the material, methods, results, and Dr. Ruff will then talk about the discussion, and we'll end with the conclusion and time for questions. So the objectives of this paper demonstrated that the residual supernatant material is a source of both cellular and cell-free DNA. And this valuable source derived from fine needle aspirates underwent molecular tests which were compared with the formalin-fixed paraffin-embedded tissue. Centrifugation settings on the supernatant overall cellularity and tumor cellularity yield were also evaluated. And then finally, delayed molecular testing after 3, 4, and 7 days were also looked at. So personalized medicine and targeted therapy really requires ancillary testing of neoplastic material obtained on biopsies. And minimally invasive cytology specimens are often the front line of diagnostic, prognostic, and predictive analysis of tumors, as we all know. But minimally invasive specimens are often minimal. The neoplastic material may be exhausted as part of the diagnostic workup as multiple immunostains are done. And when this happens, a repeat procedure may be needed to procure additional material for molecular analysis. There have been previous studies done by some of the stalwarts in this field, and they've looked at the feasibility of performing molecular testing on FNAs, effusions, washings, lavages, brushings in various fixatives, and have been quite successful. So the methods used have also had very successful results, and various molecular analysis used, whether it was multiplex PCR, next-gen sequencing, again, had extremely successful results. To maximize yield, prior studies have been assessed, which included the residual preserved site or the supernatant from specimens. And these studies have shown that these derivatives have molecular material that can definitely show positive and very robust molecular testing. So circulating cell-free DNA in the plasma or serum has emerged as an alternative method for detecting the EGFR, the T790M mutations in patients with suspected adenocarcinomas, but without tissue available for testing. And compared with plasma and serum samples, supernatants contain more abundant cell-free DNA and high mutant allele frequency, making supernatants a very promising substrate for molecular testing. So the purpose of this present study was to validate the use of cytology supernatants for molecular testing by comparing the results with those from current clinical testing substrates used in the author's lab. And these were done on formalin-fixed, paraffin-embedded material from cytology cell blocks, or from the surgical tissue blocks, or from fresh, unaltered fluid specimens, preserved. So with that, I'm going to hand over the presentation to Dr. Lu, who's going to then talk about the material and methods that were used and the results obtained.
Okay, thank you. Thank you, Dr. Nawgiri. We started off collecting cases in a prospective manner. So we went from June 2018 and January 2019, and kind of looked at saved supernatants from cases that are likely going to require molecular testing. And these are, things like lung adeno, melanoma specimens, and they come in two flavors. We usually get FNAs, either they're submitted fresh. So for the most instances, they're obtained through eBus, where we attend the rapid on-site assessment. And those that are submitted into the lab, just cytolite fixed already. And plurofluids, which are submitted fresh. Next slide, please. And so, it looks like a bit of a complicated thing, but I just kind of want to show the audience kind of the workflow of our lab. If you look at the very top, if specimens are received, we're talking about a clinical workflow here. So specimens are received in cytolite. We usually make a thin prep, and we have the option to then use whatever left material that's in the preserve site and extract the genomic DNA for molecular testing. And then in the very bottom, fresh specimens that we received in the lab, either the fresh specimens themselves can then undergo DNA extraction and then undergo molecular testing, or fresh specimens, because we're going to make a cell block anyway to do our ancillary testing, IHC, PDL1, things like that, that we can then send curls to the molecular lab to have DNA extracted. So there's kind of two routes that we can go about. The supernatant is kind of produced in kind of as we're preparing these clinical samples anyway. So, in the cytolite specimen, we have to spin it down and then add the preserved site material, the fixative, in order to put it to the thin prep machine. There's where the supernatant comes up in that scenario. And the fresh, when we're spinning down the cell pellet to, put into histogel to make a cell block, that, we create supernatant. And the thing is, these are usually just discarded, but in this study, we actually kept them and see, how they kind of perform compared to the clinical sample. The supernatants produced in our lab, our protocol is centrifugation 1 minute at 600 G. Next slide, please. So there is a couple of molecular techniques that has been employed in this study, and most of all, it's chosen based on the amount of a DNA that is extracted, and obviously because of the different kind of coverage each techniques has, the DNA requirement from the very beginning also varies. So the workhorse in our laboratory is the next generation sequencing using the Illumina platform, which in that particular year that our study was done, we use a tumor panel that detects 15 commonly altered genes in tumors, including like BRAF, EGFR, KRAS, and so on, and real-time PCR using the Entrogen platform, and that detects over 50 recurrent mutations in the EGFR gene. Digital droplet PCR is a laboratory developed test, which specifically looked at only 3 variants of EGFR mutations. The restriction fragment length polymorphism, again, a lab developed test that looks at only 2 EGFR alterations. And then then we included one case of head and neck squamous cell carcinoma, in which we tested for high-risk HPV genotypes. And then lastly, using the HPV linear array. And then lastly, we had a case of melanoma, which we use amplification refractory mutation system, and looked at BRAF, V600E, and V600K. So next slide, please. So here's kind of the breakdown of the patient cohort. Our kind of age at diagnosis around kind of the 60 years old, kind of older patients. It's quite an even split between females and male patients. And 10 supernatants were excluded because initially I mentioned 55, and 10 were excluded from testing because they are usually in the EBUS, they sample multiple nodes. And if we find similar things, or if they're negative, we only send one of the representative samples for molecular testing in the end. So the overwhelming majority of these specimens are lymph node FNAs, usually in the EBUS setting. There's 10 lung FNAs, and a sprinkling of neck FNA, axillary FNA, pleural fluid, and lung resection, which is one of the comparison clinical specimens. And diagnosis is expected since they're EBUS samples. Most of them are adenocarcinoma, with one kind of favoring adenocarcinoma and one case of squamous cell carcinoma malignant melanoma. Next slide. So initially, we looked at whether or not are there anything to be tested in the supernatant sample. So we prepared a field stain cytospin. For those of you who don't know what field stain is, essentially a Romanowski stain that we didn't use the brand name account. We developed a stain in our lab for price purposes. And this is at 100x, showing that there are indeed intact tumor cells in this preparation. So there are indeed some cells in the supernatant still. Next slide. And so we went on to assess all the supernatant that were tested, underwent molecular testing, and see kind of how the cellularity the distribution is. So in the table you see overall cellularity, and then it seems like most of them are still in the high cellularity range, meaning greater than 500 cells. There is maybe 13 of them, about 30% of them, kind of the moderate cellular range, like 100 to 500 cells, and then the low, there's 20% of them that has less than 100 cells present, and those are the kind of overall cellularity. So it includes tumor and kind of other mixed cells, macrophages, lymphocytes, what have you. And then when we looked at the tumor cellularity themselves, the range is actually quite wide, with those that ranging from less than 5% to even over 90%. And actually, over half of them falls kind of in the low category, less than 5. And 10% of tumor cellularity. And these are scored by 2 cytopathologists independently, just visually. And next slide. So initially we wondered, if altering any of the pre-analytical variables would affect kind of, the cellularity. So we kind of chose 3 cases that we had a lot of material on, and kind of tested different centrifugation settings and see kind of how it affects both the overall cellularity and the tumor cellularity. So in the kind of the middle of the table at 1 minute, 600 RPM is kind of our standard that we use to produce a supernatant. And as if we look at case 5, we have a moderate overall cellularity with 10% tumor cellularity. And if we kind of decrease the RPM, the tumor cellularity kind of increased from 10 to 70%. And it seems like, spinning it as compared to the unaltered, so we kind of enrich for tumor cellularity when we spun it at 1 minute at 300 RPM. But if you look at the other case, where case 11 in the middle, where using our standard, we see high overall cellularity and then 10% tumor cellularity. It seems like if we increase the RPM to 1400 or increase the spinning time to 3 minutes compared to the original one, it doesn't seem to have much of an effect on a tumor cellularity. It did kind of got rid of some of the other cells, it seems like. And then in the last case, where similar to case 5, where we kind of see if we kind of spun it with less force and see what happened, it seems like kind of the optimal range is kind of at 1 minute at 300 RPM. So next slide, please. So then we wondered if, a lot of the times there's like, delay to testing, and, DNA kind of does degrade if we do nothing in it, we just let it sit. So we wondered if any of this would affect our molecular testing. So again, we chose 2 cases that have a lot of material left over. And in case 10, we're immediately DNA extraction and then submitted to NGS testing. And also, held the specimen at 4 degrees Celsius, put in the fridge, and again subjected to NGS testing, and they both found the same molecular alteration in HER2. And then if you look at case 11, again, we immediate DNA extraction compared to 3 days delay in DNA extraction, and 7 days showed the same EGFR mutation. Next slide, please. So now going to the meat of kind of our study. So first of all, we kind of separate our cohort into fresh supernatants, so things that came fresh, and then we spun it down and kept the supernatant. Sorry, there's a window keep popping up. Okay, so 35% of them went. Most of our specimen did undergo NGS, I guess, except for the fresh supernatant cohort, where a lot of them actually underwent RT-PCR. And then in the cytolytic supernatant, where we received the specimen in fixative, and then we spun it down, and that supernatant, it's kind of a halfway divide between like NGS and RT-PCR. And then one case was a head and neck squamous cell, so one of them underwent HPV linear array. And then the comparison clinical samples, overwhelming majority of them did undergo NGS with a sprinkling of other techniques that we've mentioned previously. Next slide, please. So here's the comparison material. So in the fresh supernatant cohort, most of the comparison clinical sample is a cell block, which, kind of our normal workflow in our lab. One of them was a fresh preserved sit fluid, and one was a fresh specimen, and then one was a surgical resection specimen, which we just chose one block and was microdissected to enrich for tumor cellularity and is submitted for testing. In the cytolytic cohort, there's less cell block. There is more residual preserved material that was submitted. Next slide. So here are the results. When we compare the fresh supernatant to the clinical samples, we found a concordance rate of 87%, so 3 discrepant cases. There was substantial correlation. Compared to the cytolytic supernatant, there's only 1 discrepant case with almost perfect correlation, giving a total or overall about 91% concordance. Even though there's, visually there is differences between the concordance rates compared to the fresh and the cytolytic supernatant, it does not reach statistical significance. Next slide, please. So if we delve into the discrepant cases, so the top table talks about the fresh supernatant, and the bottom table talks about a cytolytic supernatant. So looking at case 7, both case 7 and 12, actually, both the fresh supernatant and the clinical sample were tested using the same platform, the TST15, as I described previously. And both of them kind of show partial correlation, meaning that they were able to detect some of the mutations in the supernatant compared to clinical sample. sample. And as seen in, let's say, case 12, there's one TP53 mutation that was found in this fresh supernatant that was also found in the clinical sample, but the second one was only found in the clinical sample. And in our last case, of the fresh cases, case 23, there was 2 EGFR mutation that was quite close together, and they were unable, in this fresh supernatant that was tested using RT-PCR, they were unable to detect both EGFR mutation compared to the clinical sample. Interestingly, in the cytolite fixed supernatant, kind of the reverse is true, where we have a KRAS TP53 mutation and a HER2 mutation, and interestingly, in the cytolite fixed supernatant, they were able to detect all 3 mutations, whereas compared to clinical sample, they were only able to detect the KRAS mutation. And again, they're both tested using the NGS platform, so there really is no difference in coverage. Next slide.
All right. Now has Heather joined us?
Hello.
Oh, hi, Heather. So Dr. Ruff is going to take over the discussion from here. She was away at a procedure and came in for discussions. Thank you, Dr. Ruff.
Thanks. Sorry about coming in late. So yeah, I'll take the discussion portion of the presentation. So the cytology supernatants and specimen derivatives like residual preserved have been successfully used for molecular testing of varying different methodologies across varying types of tumors and sampling techniques and collection solutions or fixatives. In our article, we reviewed 26 prior studies that have been reported since 2012 that looked at this. There's a table in the article for completeness. I'm not going to go through all of it right now, but feel free to have a look at that later if you're interested in some of them. And I think we'll just keep seeing more. They continue to come. In our study, we compared the molecular testing results on supernatants that were both fresh and fixed supernatants with those for clinical samples. Some of the prior reports assessing supernatants in molecular testing and cytology say that one of the issues with supernatant testing is that there's an inability to assess tumor cellularity. We actually did assess tumor cellularity on our samples, as Sandy described, by using field stained cytospin slides of 150 microliters of supernatant. Next slide. So DNA fragment size was not assessed in our study, but it has been assessed in many previous studies. Molecular alterations have been detected, and it has previously been reported that molecular alterations have been detected in samples of supernatant where there are few or no tumor cells present. And this has led to a suggestion that the supernatants may contain predominantly cell-free DNA. However, there have also been some quantitative analysis of supernatants that have shown 2 peaks of DNA fragment size. There's multiple studies on this, and generally speaking, they show 2 peaks, a low molecular weight peak, which is felt to correspond with cell-free or circulating tumor DNA, and a high molecular weight peak, which is felt to correspond with cellular or genomic DNA. And in some studies, the cellular or genomic DNA component has been predominant. Yang et al. Also had a DNA fragment size assessment, and in one of their studies, they found that there was an increase in DNA fragment peaks, variably increased for some specimens, and that occurred between the peaks. And this suggested, they postulated this would be partially fragmented DNA from tumor necrosis or destruction by macrophages. Next slide, please. So there are a lot of theories of what the genetic components of supernatant may be from, and those include the genetic material from necrotic cells, genetic material from cells that are damaged in processing, such as and including centrifugation, circulating transudate from circulating tumor DNA, cell-free DNA in a peritumoral environment, and exomes secreted by tumor cells. And as our specimens do show variability, there may also be some variability that's specimen dependent. So we already, assess overall cellularity and tumor cellularity, and in some of our molecular testing, we look at necrosis as well. And so some of the percentage or the breakdown of what parts of DNA are there may be related to the specimen itself. Next slide. So the genetic composition of supernatant may also vary with centrifugation parameters. Of the 26 studies that we reviewed, only 15 actually reported their centrifugation parameters. And among those that had reported them, there was really wide variation in the centrifugation parameters that were used. This may have implications for what extraction method you might want to use or what molecular testing you would want to do. This study, our study, included a very limited assessment of tumor cellularity and centrifugation parameters and did not include, as I said, DNA fragment analysis to determine the percentage or the peaks for different DNA fragment size, which would have been helpful to be included in retrospect. In our study, we did see that increasing the speed did not seem to increase tumor cellularity. In fact, in some of the instances, it seemed to decrease it. But again, we have very few samples that we were available to test in this way because most of the samples were quite limited in volume. So further studies are needed to determine an optimum centrifugation parameter that will allow for a creation of a cell block for IHC and biomarker testing, as well as use of supernatant for molecular testing. Next slide, please. Other limitations of our study included small sample size with an N of 55. Different extraction methods were used for supernatants and clinical specimens. For supernatants, our molecular lab used a cell-free DNA extraction kit, whereas for clinical specimens, including the cytology specimens with residual preserves, they used a genomic DNA extraction kit. And this may have affected our outcomes. A variety of clinical specimens were also used for molecular testing. In our lab, it's quite rare for a concurrent FNA and core to be done, or in a hospital. So those samples aren't usually available for comparison, but what we do have is we currently already do NGS for lung adenocarcinomas and other molecular testing on cytology specimens for formalin-fixed paraffin-embedded cell block material and residual preserves, which were the two major portions of the comparators in our study. On one case, we did use a surgical block because a cytology cell block was, a cytology cell block was not available. And on one case, fresh unaltered fluid specimens where a specimen was used. And those all are things that were available in our lab in addition to using scraped smears for our molecular testing. Next slide, please. We did try to assess delay in processing. We did a very limited evaluation of this and for our fresh specimens only, the fresh refrigerated specimens that were kept at 4 degrees C. And we didn't see discrepant results in the specimens that we looked at, but it was a minority of the specimens involved due to availability of extra material. However, the fixed supernatants did seem to outperform, although not statistically significantly, seem to outperform our fresh specimens, having less discordant results. And so maybe there's some effect that we weren't able to detect in our very limited evaluation of delay in processing. Additionally, I should point out that our molecular testing panel at that time did not include RNA-based testing. And so the extraction or suitability of this for our samples for RNA was not evaluated at that time. We have since added RNA to our NGS panel for our lung adenocarcinomas. And so that's something that we're going to have to keep looking at and working on. As I think Sandy pointed out, that some of the previous studies have looked at effects of storage on specimen DNA extraction from specimen and RNA extraction. And there have been some interesting findings. There's a thought that if you store a specimen for some amount of time, especially a fresh specimen, that there could be degeneration and you could have less good DNA extraction and molecular results. But interestingly, Heyman et al. Found that there was in a recent evaluation that duration of storage time was weakly correlated with quantity of DNA extracted, independent of cellularity. And they also found that in a subset of cases, cell-free DNA recovery increased over time and not decreased. So that's quite interesting. Definitely more studies on effective storage for fresh specimens on quality and quantity of DNA and RNA extracted are needed. Next slide, please. So in our study, there was excellent concordance of the molecular results in the supernatant samples with their clinical counterparts. We did have the 4 discrepant cases that, as Sandy pointed out. 3 of them were in fresh supernatants and 1 was a fixed supernatant. Again, kind of bringing up the possibility that maybe delay in processing could have had an effect. 3 of the 4 discrepancies also were seen when using the same molecular testing method, NGS. And so we didn't expect to see those discrepancies. The discrepancies couldn't be related to the molecular testing method used or mutational coverage. Next slide. One possible difference that I pointed out a moment ago is that extraction methods were differed between the 2 sample types, the clinical and the supernatant, and we thought this could have led to an inherent difference in DNA composition between the samples, despite comparable amounts of DNA being extracted. And this could also explain why the tumor cellularity alone did not seem to affect concordance, though also the variability of supernatants genetic composition may explain that as well. Additionally, the variant allele frequency of the molecular alterations detected in the matched samples also varied, and we thought it might be related to these same differences. Next slide, please. Testing of the supernatants for molecular diagnostics makes use of an otherwise squandered portion of cytology specimens, and this preserves residual material and cell blocks for necessary ancillary testing such as immunohistochemistry, and thus in turn minimizes the need for additional sampling, thereby decreasing procedural related costs and risks. Our study did not involve the cost analysis, but there are previous studies that have shown this. Additionally, previous studies have shown that using supernatant instead of FFPE from clinical samples can decrease turnaround time for molecular testing results by as much as 3 to 5 days. This would be even more so if you had to collect an additional sample, I might point out. Next. For cases where there's other material available, where there's no other material available or material isn't suited, or additional sampling may be difficult, testing a supernatant may yield an expedient, meaningful result for clinicians and patients when a clinically actionable variant is detected. For cases where mutations are not identified in supernatant, similar to recommendations for plasma or cell-free DNA, repeat testing may be performed if and when an alternative sample becomes available. Next slide.
And with that, we come to the conclusion of this eJournal. The conclusions that the authors came up with, which in this very, very elegant and I think a powerful study, given the fact that you know, we have such small material to deal with, was that, you know, they found that the supernatants derived from clinical samples are a suitable substrate for molecular testing of clinically actionable variants in lung carcinomas using a variety of molecular techniques available in their institution. There was good concordance between the 2 sample types, and the pre-analytical variables, centrifugation settings, specimen fixation, delayed processing, variable tumor cellularity of the specimens, and the variable DNA composition of the supernatants could have contributed to some of the discordant results. And finally, the ability to use the supernatant, which is otherwise a discarded portion of the specimen, of the cytology specimen, will allow to maximize the utility of each specimen to meet the increasing need for biomarker testing. With that, we come to the end of the presentation. If there are any questions, Dr. Rezai should be available to let us know.
Yes, thank you. As I said, the technical difficulty kind of got me in and out, so I'm not seeing any questions in the question box or in the chat. I do see a thank you, and I appreciate that. But right now, I'm not seeing anything. But until I hear more or see more, I'm going to say this was very nice study, nicely done and nicely presented by all the presenters today. And I guess as cytopathologists, we always kind of find a way to do more with less. So I think that's the theme. And I think it's very important, especially with the plethora of new things that we have to deal with and do with the patient's material, which are very scant at times. I think studies like this are very essential to let us kind of use whatever we can. I think if anyone can do it, cytopathologists can do it. So that's the bottom line. And I really think it's a breakthrough in a sense, because we were very happy when we got all the biomarkers, prognosticators, and all the things that would be greatly used and help the patient care. But we kept coming to the issues that we're not really being able to sometimes use the tiny core biopsies, which are crushed and you can't even see, let alone to do prognostic markers on. So in that regard, I guess we are, we are very grateful for studies like this. So thank you so much. I think I am getting something as a question. So let's see. Okay, how she explains detection of TP53 in cell block but not in supernatant. So
I think there were 3 different discrepancies in the fresh tissue. It must be, I think, are you referring to one of the fresh samples or the fixed sample? We definitely detected TP53 in a fixed sample that wasn't present in the corresponding clinical sample. I have to go back and look and see if the corresponding clinical sample was a cell block, but probably it was residual preserved. Regarding the other 2 or 3 cases with the lack of correlation, we don't have a clear explanation. We had a lot of variables in our study because we used all the different testing techniques that were available in our lab. The testing technique that was selected for the specific sample was actually selected in molecular pathology by our molecular scientist based on DNA concentration extracted from specimens and tumor cellularity. So those are the 2 main metrics that they used. You can see that some of the methods were exactly the same. So for 2 of the cases, or 3 of the cases, I guess, where NGS was the same, 2 of which were fresh, and there was a mutation that wasn't detected in the cytolite supernatant, but was detected in the clinical sample. There was 1 where a mutation was detected in the cytolite supernatant, but not in the clinical sample. So for the 2 fresh ones, I'm guessing those are what you're referring to, and we're not exactly sure. We know it's not related to testing methodology because the same methodology was used with the same NGS panel with the same mutational coverage, so it shouldn't be related to that. What we don't know is if it was related to the difference in extraction technique or if it was related to some other difference in specimen processing. We looked at the specimen processing for delay of processing, and when we did that small subset study of it, we didn't see an effect. But not all specimens were processed immediately. Every now and then you end up with something on a Friday and it doesn't get processed to Monday. So some of those things, so they would have been put in some fixative for storage. In the molecular lab, I think they're using, I don't know, I have to go back and look, but there may have been effective delay in processing there. Or that they have to do the extraction and they don't get around to doing the rest of it. There could be a delay in processing that we haven't picked up on, and that might be one reason. The extraction method difference might be another reason. Those are the 2 main things that I think that we're concerned about or considering, but that's we're not entirely sure. I suppose another possibility and a reason that the extraction method is actually something to consider is when we were optimizing our centrifugation, we were looking to keep tumor cells in the supernatant so that there would be a cellular component. But since our molecular lab was doing an extraction really for cell-free tumor DNA, like did we pick the correct extraction process? Or perhaps we should have done some kind of modified extraction that instead of using just a standard kit, something more than what you would do for your cell-free DNA, but not as intensive as what you'd use in your extraction kit for genomic or cellular DNA. Those are our considerations.
Very good. There's also a question that says, please show Dr. Liu's last 2 slides. So I don't know if it's easy to go back to that or not. And the question also says the table shows NGS did not detect in supernatant. I think that's what you also were discussing. And the next question is, did you detect TP53 mutation in any supernatant? I guess that's okay.
I'm just looking at the table in our paper. Yeah, let's see. Yep. So if you refer to the paper, there are cases where the TP53 mutation were concordant in both the supernatant and the clinical sample. For some reason, and like even with it didn't seem like it was a specific mutation that's different, because as you see, they're kind of at different spots. So I am not quite sure why TP53 is the one that keeps popping up. Again, maybe it's something, owing to the different composition, maybe, when the cells kind of, spill their contents out, maybe, they're usually, higher grade stuff, so that have TP53 mutations, or, vice versa. So maybe they're different clones of the same tumor that, we're not capturing. If there's more activity going on or complexity that's going on in the supernatant than we previously thought.
I don't see any other questions at the moment, but if any one of you has a comment or something that you want to share, this would be a good time to do so. I know you kind of said everything that you wanted to say in your discussions and your presentation, but I guess
I guess you can. I can try and say something. And there are only two other things I can really think of at the moment to say. One is, we are kind of in a way redoing or adding more to this now, because now that we've added RNA to our NGS panel, we have to evaluate how appropriately and how our specimens are behaving for RNA. So with the new panel that is being implemented next month, we'll start looking at this for cytology specimens as well. And in the meantime, we'll be running them on the other specimens that we already have validated, so FFPE and residual preserved set. But we'll have to add some of our other types of specimens that we can use in as we gather enough of them. So we don't have enough at this point to say that it's validated for use on like destain slides, scrape slides, or supernatant, or I think there's one other thing that we're going to add to that. But the residual preserved set and the cell blocks seem fine. So we'll keep an eye on that and have more to report in the future, maybe. Another thing that I'd say that is something that we alluded to, is that sometimes the cytology sample seems to be better, or to pick up mutations that aren't present in the clinical sample. We saw that with one cytology supernatant here, but it's not a phenomenon that's specific to our study. It's something that's been seen in other studies as well. So there may be, instances, or there may be something about some supernatants or some cytology specimens that actually make them superior to surgical specimens. It could also be related to location, because some of those studies don't look at same site analysis. Ours actually did, so all of them are, with the exception of the one surgical specimen that was included, all of them are same site or site to site. So the cell block and the supernatant and the residual preserved, so everything's coming from the same site in the molecular testing comparison here, and we're not comparing to a different site or a different time period. And so some of the variations in other studies could be explained by that as well, the difference in site or difference in location, or a difference in timing for the patient too. Is this an original sample, primary, or subsequent, or metastasis?
I have one more question that is asking, did you address that not all mutations are detected by NGS of supernatant in your paper? I will let you guys say it. I kind of have my thought on it, but
I think that whenever you're doing a validation, or whenever you're looking at, doing a study like this, you do come across a case every now and then where something doesn't. The majority of our cases, we did detect mutations, and we detected them in the clinical specimen as well. So there were a few cases where that didn't happen. There were cases where there was something detected in the cytology sample that wasn't detected in the supernatant, that wasn't detected in the original sample. And then there were a couple cases where there were mutations that were detected in the clinical sample that were not detected in the supernatant. And we don't know exactly why that is. It could be based in the difference in extraction methods. In one case, it could be related to the testing method used, because there is the other two cases, or three, one being a cytology sample that performed better than a clinical sample, and two being clinical samples that perform better than cytology samples, we're not entirely sure of what the discrepancy is related to. Again, it could also be related to time, because while we did try to look at delay in processing, some of the samples were not processed the same day. And so it could happen to be that it was one of those. Whenever possible, our molecular lab tries to do process samples the same day, but every now and then something might happen, and so it could be related to delay in processing for the fresh specimens.
Very good.
If you have other ideas, I'd be glad to hear them.
So let's see. Could the pattern of cells in the supernatant, single cells, cell clusters, or tumor type have influence in determining the RPM?
Yeah, I mean, obviously things that are bigger would kind of settle out. Like, I mean, this is just kind of anecdotal. We do deal with a lot of lymphomas. What I found is that, if you kind of use the same setting, obviously with the small, B-cell lymphomas, if you center for flow, there's way more cellularity than if you send a large, B-cell lymphoma supernatant. It's just, yeah, the cell size itself, obviously, if you increase the RPM, they'll settle out. And, sometimes, you try to tweak, and then at some point you just kind of lose everything. So, it's just optimizing, because obviously the lymphocytes and everything's smaller. So, we just have to tweak and see. And this is because most of our tumor samples are lung adeno. So who knows if you have a fully differentiated, a tumor that has really large cells, like obviously the settings will have to be adjusted.
Very good, thank you. Mm-hmm.
Dr. Raff and Dr. Lowe, would you ever consider doing any of these molecular studies on direct smears?
Yeah, actually, so we do sometimes in our lab. Usually it's kind of as a last resort, and we had looked at it for some things. So we do get a lot of EBIS with lung adenos, and that's probably the predominant thing that we would try it on. And we have success in using scrape smears for NGS. They weren't included in this particular study comparing to supernatants, but we do occasionally use that. And if it had happened that we had a case where we had great smears in a not good cell block, and hadn't reserved supernatant for some reason or something, we would send the scrape smears. So that is something that we do. Again, that's one of those things that we haven't validated for the RNA though. So I think the RNA may end up being a challenge there, but for DNA, yes, we've had good results with sending those.
Very good. I have a question that is a generic question, not necessarily for the paper, but is how to get access to the paper. I will say my little thing about it, and Joanne can correct me if I'm wrong. This is in the Journal of American Society of Cytopathology, so JASC for short, and I think the titles and the numbers and everything else is in the presentation, so you can search with that PubMed and then you get to it. If you're a member of ASC, which we really hope that you are, then you can have access to it through the ASC website, because we no longer have the paper the paper journals. So and then again, if you have access to a medical library, JASC would definitely be in PubMed, and you can have access to that as well. But again, the reference and everything is on the presentation, so you can search for that. Is there anything else that Joanne, can you tell us about it, or?
The actual copy of PDF of the article is in the handouts. I just put it up on the handouts.
That also helps a lot. Thank you. Very good. Very good. So far, I think we're caught up with the questions. So in the meantime, while we're waiting, I'm just going to ask you again, you guys are practicing in Toronto, in the Canadian system. So what is your reflex when there is a lung adeno diagnosed, cytology, search path, wherever? What is your reflex panels for the markers that we are discussing? Is it NGS now? Everything is done by NGS?
Yeah, that would be the preference. Is all of our physicians and clinicians want the NGS, and recently Ontario Health Insurance, or OHIP, which is Ontario Health Insurance Provider, I think. So the provincial government started paying for NGS testing. I think that was for lung, not for everything. Since then, the NGS panel has been expanded. Previously, we were doing ALK and ROS by IHC and PDL1 by IHC, and now we do NGS panel, which does include ALK and ROS and a bunch of other things. I'd have to give you a list of markers. I think it's actually in the paper, but we are changing that now too to add RNA. So that's the old one. I don't have the other one in front of me, but so it's a kind of a pretty good list, I think, there. And then we do the PDL1 by IHC still, of course.
Okay, so PDL1 is still IHC. Very good.
And we validated the readout of PDL1 on cytolite fixed material. So we'll do it on formalin fixed or cytolite fixed material, but we haven't validated for anything else. So right now we're just doing our own cell blocks. We have a histogel method that we've done in-house, and we don't take other cases that are our different types of cell block preparations like Cellularity or something like that.
Very good, very good. Yes, again, this is a constant struggle, at least for me. Right now, I'm working at the Quest Diagnostics, and we receive specimens from all over the country. So, and many different methods of not only getting the specimen, but also preparing the specimen. So, it's not any day that I go through my piles of PDL1s, which are so fun to look at. I'm sure you all agree. And then we have to kind of go through that. Okay, this was fixed this way. This was prepared that way. So we can only do this thing. And for the FDA approval of the medication, this cannot go and this can go. So it's a lot of different ways of having to deal with. So, and then for the most part, a lot of our cases still get, separate, not necessarily the NGS panels. But I think it is a move that is going. We have very robust NGS panels that we offer here, but I think the medical oncology is kind of moving up with that. So at some point, it may completely replace what we now do. A lot of people do the separate ALK, EGFR, ROS, and all of that. So. We'll see how that goes, but very good, very nice. I was hoping that you have something for PDL1 that I don't have to look at the IHC, but I guess now we don't have that.
No, unfortunately not. I really wish I did.
I know the inflammatory cells and the macrophages and everything else that is picking up. It's just it's a lot to process when you're looking at the PDL1, but I guess we do what we can do best. Very good. Very good. I guess we are caught up in a way, and I don't think we have to stay up till 2 o'clock. If there is no other questions and no comments, I do not see anything. Oh, actually, sorry, I was wrong. Which pipeline you are using for variant calling? I guess that's
for variant what? I'm sorry.
It's what
variant
I'm reading.
Calling.
Variant calling. Yeah.
We don't actually have our molecular person with us in this call. Let's see, Sandy, do you have that information?
Yeah, well, it is some sort of, well, I personally am not a molecular pathologist, I gotta say, but we do some in-house developed pipeline that we use, but that's all the details I know.
If you want more information on that, you can just send me an email and I'll give you that. And if you wanted the list of the molecular panel as well, Katie, I can get that for you. Just
sure.
Send me an email. I think my email is in the presentation information, but if it's not, I'm happy to put it in the chat.
Sure. Maybe that would be great to put it in chat so that people who want to directly contact you, they can do it.
Okay, I typed it in. It's real easy. It's just my name. So heather.ruff@uhn.ca, and it should be in the chat there. And if you have any questions about that, just give us an email and we'll figure out, get you whatever information you want.
Exactly. No, it is. I can see it in the chat. And again, if we receive anything afterward, I will definitely forward it to you guys for your input. That is very good. Let me go back to my question box to make sure that I'm not missing anything else. So far, no, I did all of them, I think. Oh, I didn't. You guys answered it, but I kept them in line. Very good. Very good. Perfect. Okay.
Okay. Thanks for keeping us in line and getting us all the questions. And I hope
No,
you guys
absolutely.
enjoyed our presentation, and let us know if you have any additional questions that we can try and answer.
I think by the amount of interaction, I think everybody enjoyed and everybody had questions to ask. So thank you for you guys for giving us your time. I really appreciate when the authors agree to be at presentation, because that really makes a big difference in how we can handle it and how the audience can get their answers responded to. Again, one more time, thank you very much, everybody. I'll let Dr. Nawgiri to say the last words, and then after that, we'll say goodbye.
I just want to thank both Dr. Raff and Dr. Liu for their time. I know how, you're kind of very, very short-staffed right now. So I really appreciate this. And, this is, I think, a very, very important topic that the cytology community has to be dealing with. And you guys have done an amazing job. And thank you for being here for the presentation.
Thank you very much for having us.
Thank you again, and hopefully you have a great rest of the day. Thank you. Bye-bye.
Goodbye.
Bye.
Bye.